So, good morning, everyone. I am Carla Romaitis. I am the lead for the Innovation Scouts. I just want to take you through a few things today, some norms to expect. So, for the webinar today, I'd love you to be able to try and raise your hand, so you can have a little go of that now. We would like to take questions after we've spoken, so that would be great. It doesn't mean that we will answer you. It just means that we may not be able to answer you straight away. So we'll unmute you so you can actually chat and participate. We're going to ask you a few questions that you can engage in the chat box with. And there's also an option for you to answer and ask some questions, and you can also upvote them. So if you make yourself familiar with that setting on Zoom, that would be great. So if you think that's a really good question, I'd like that to be answered, the ones that get upvoted will be asked and answered first. We'd also love you to tweet as well. So our Twitter handle is @innovation_NWC, and our hashtag is #InnovationScouts. As I say, the webinar will be recorded and the slides will be sent out to you all via Eventbrite. I'd also like to invite you all to sketch notes and capture your ideas today. So it's always a really good way to engage in any information that we get given. So for those of you who are familiar with sketchnoting, please feel free to do that during the session. It'd be great to see some of your ideas and your designs. And as I say, for any detailed or any specific conversations from today that may not be answered or that you might want to pick up after the session, then please email me. It's carla.romaitis@innovationagency.nwc.nhs.uk. So just a little bit of a lineup today. So I'm going to do the introduction. I've got some community questions for you. So we really do want to get some feedback and see what's happening in your areas. And we want to see how you've actually adapted to some of the digital change recently and, throughout the past year. We've got Jenny West, who's our Associate Director of Digital Change, and Adrian Quinn, who's our Programme Manager of Digital, that's going to be contributing today and giving us some real insight into digital change. It was a great conversation that I had with Jenny and Adrian. I think it was last week now, and just picking up so much more new information. And digital as a subject is so vast that actually we've changed some of the outcomes that we'll hear from today, really in line with what's happening with COVID and the situations that have changed since that has happened. And then from 12:30, we'll open it up for some Q&A and some sharing of information, and then we'll wrap up with some summaries. So just an introduction for those who've joined today who aren't an Innovation Scout and are kind of wondering what this is all about. So it's a community of practice run by the Innovation Agency. It was relaunched in 2019, last year, and it brings together lots of tools and approaches and really develops a culture for innovation, giving you entrepreneurial skills and supporting you through coaching and mentoring. We've also now got 12 peer mentors that are on the programme that can offer you support in your own practice. So it's something that you can apply for, and you can join us if it interests you today. And from the Innovation Scouts, we developed a list of priorities. So there's 83 of us in the community, and digital was one of the priorities. These are in no particular order, so it's not as if, digital was third on the list. These are generally the 11 topics that people felt were a priority for us in terms of innovation, or what people really wanted to learn more about. And as a result of this, we will be holding more webinars, coaching sessions and workshops around these topics. And the first one today is digital. So in terms of the curriculum map, these are the things that we are going to be looking at. So this year, so digital, patient education, barriers to information sharing, and we're going to deliver those in a few different ways through webinars and keynote speakers, and also through peer collaboration when we hold workshops and coaching sessions. Pays into innovation, research and evaluation, and funding, and you can find all those links available on our website, and we can also share them after. So as I say, we've got 83 members across the Northwest Coast. To join the Innovation Scouts, you should be working on an innovation in health and social care, or really want to develop some innovation skills or mindset. And the only stipulation is that you must work within the North West Coast region in order to join the programme. Okay, so I'm just going to come out of this and stop sharing, and I want everybody to use the chat function. And what I would like you to type in is, the first question is, what was the last app that you downloaded? So I really want everybody to type in, and you should put all panelists and attendees that you'll be able to share with. And I want to know what was the last app, and it doesn't have to be anything to do with work. It can be anything that you've used at home. Lovely. So we've got MS Teams, Airtable, Zoom, Sleepio, House Party. Yeah, House Party. I've heard of House Party. MS Teams, CBeebies, Zoom, Duolingo. Oh, I wonder what that is. EE. Oh, I've never heard of Duolingo. That's quite good. Fitbit, MS Teams. Last app, COVID-19 app. Mahjong, brilliant. Affinity, Photo, Plum. Scove Piano, wow. So we're going to share these as well after. We'll make a list, and I'm going to have to familiarise myself with some of these as well. That's great. And I would like to know the next question. So one thing that you've done virtually that you never thought you would. So one thing that you've done virtually that you never thought you would. What's it enabled you to do recently? Personal training. Have a coffee with colleagues, meetings, beers with mates, lovely. Yeah, family quiz, they're very popular at the moment. Yeah, virtual yoga, quizzes, blankety blank. That's fantastic. I remember that from years ago. Somebody's portrait. Oh yeah, I love a bit of annotation on the Zoom, that's fab. Yoga too, yeah, art lessons. That's great. These are lovely. So the next question is, and I'll give you a bit more time for this. So one piece of advice that you would give to someone using a new piece of tech for the first time. So what would your advice be to somebody using a bit of tech for the first time? Play it till you break it. Don't rush. Yeah, test it out. Practice first. Patience. This is always a really useful one to have. Patience. Prepared to get it wrong. Absolutely. Keep trying. Really good idea. Test it out on a mock project. So do something that's not going to have that consequence of it being wrong, or a big consequence of it being wrong. Yeah, you might not get it right. It's okay. Have fun with it. Yeah, that's a really important part. You know, don't be intimidated by technology. Lovely, Andrea, like that. Absolutely, because it can be really intimidating if you think, you know, there's a link, there's this, especially it's got loads of different components. I find myself feeling a little bit like that, so that's really important to remember. Fab. And so the last question is, can you share a failure so far of when you've been using technology and what happened? And I'm going to share my story of when I set up a coaching call last week, and I sent the wrong link out to many people, and it was a disaster for about 5 minutes, and then we written it. We written it in and made it right. Yeah, not sending out dialing details, just forgetting some parts of this that needs to be connected. Absolutely. I'll just wait for a few more comments. Ending up in a meeting on my own as I didn't realise the link had been updated. Yes. Dialing into the wrong meeting and not realising for a while. Taking care with reply to all. That sounds interesting, Jenny. Not realise, yeah, muting is such a big one, isn't it? Not realising that you're being muted. Bandwidth not sufficient enough. Yeah, so all these technical things, whether or not it's going to work. Dialing into the incorrect meeting. So I'm glad I'm not on my own. That makes me feel so much better. Look at the camaraderie that we've got here in terms of this. That's brilliant. And so, as I say, we're going to capture some of these. Yeah, not unmuting. It's just, and is it control and space when you're on Zoom that allows you to unmute? And I learnt that last week. Entering the same number conference in another meeting. Yeah. These technical things that can just sidetrack us a little bit. Really interesting. So we will collate these and we'll send them out, and we'll make a little one pager of all these things. I think it'll be really interesting to share. So that's it really for my part of it. I'm going to now introduce you to Jenny West and Adrian to introduce their digital landscape in a post-COVID world. Jenny?
Hiya, can everybody hear me? Can you hear me, Carla?
I can. Brilliant.
Good. You have to check, don't you, these days with all of this?
Well, absolutely, especially considering what our attendees are saying. Mute is obviously the biggest problem.
Exactly. I have spoken for 10 minutes without realising I was on mute. So yeah, I'm Jenny West. I'm the Associate Director for Digital Change here at the Innovation Agency. I've been with the agency for about just 18 months, I think, about now. Adrian?
Hi, yeah, I'm Adrian Quinn. I'm the Programme Manager in Digital Change. I've been in the Innovation Agency for a couple of years now. Background in social care, so that's one of my areas that I focus on.
Okay. So if we move on to the next slide, I know we did get some initial questions from Carla, but I think when we were asked to do this, we decided we might change it up a bit in light of only just the last 3 months. I've got to admit, it feels a lot longer than 3 months, but in light of the last 3 months, we thought we would change it up a bit and just give an overview of what we found in the digital landscape as we start to emerge into a possible, a different world for health and social care. Can we move the slide?
Yeah.
So we thought we'd just highlight a few of the key things that obviously have really come up. So video consultation is obviously one of the major things that's become a very accelerated program within the last 3 months. So is there a problem with the sound?
No, I'm not finding a problem.
Okay.
Let's have a look. Is there something in the chat?
No, it's okay. It's looking okay. It might just be one person. Sorry, I just saw that come up. So yeah, video consultation has become a very accelerated program. So I've put a couple of quotes up from people about how this has affected them. And obviously the one from the Nye Bevan University Health Board in Wales was saying it was an R&D evaluation program which turned into an aggressive national rollout plan in Wales. When the pandemic hit, it became a very black and white issue. So something that we've been trying to do for years is getting video consultation, remote consultations working, suddenly got to be very accelerated. And some of the big, there was a couple of products that particularly came through in this time. So obviously Attend Anywhere was rolled out nationally where there wasn't solutions in secondary care, and AQRX, I'm still not entirely sure if that's pronounced right, but I've put their logo up, was rolled out again where there was no solutions. Within primary care, MS Teams became really useful. And it wasn't just about consultation. This was in an unprecedented situation about helping patients speak to their relatives, doctors oversee wards remotely. There was a myriad of uses it came out for, not just the programs of work that we were looking at. I mean, over this last 3 months, MS Teams has gone up to 1.2 million users. Because it was rolled out for free nationally to sort of support people in this area. But there's been other kind of issues with it. I mean, things like I hadn't even been aware of when I started to read up on some of the things that have been written at this point, where people were saying they had to get rid of paper notes, because otherwise you were having to separate those paper notes for 72 hours before anybody could scan them into the electronic patient record. So people were having to come up with solutions really, really fast to try and solve those kind of problems, or your electronic record was 72 hours out of date. And people would say, well, why didn't we do this before? Why has it took this kind of situation to force this through? And it's because we've always had competing budgets. Wherever we've tried to do something, digital technology has always had to prove its worth before it would be able to be implemented. And that's been difficult because benefits realization around digital has not been the best. I worked on the national program doing benefits realization for the Treasury, and even back then it was a tough sell to get people to start to realize the benefits. And a lot of the time benefits aren't realized in digital technology for years after they've been implemented. Other developments have been rushed up the list around this to be able to use it for things like virtual smart cards. But what I wanted to point out is that for every action, there's always an equal and opposite reaction to it. And where we've gone with this, and in some ways it's great, it's pushed forward something that's been on the cards for years. It's been done without any real business change behind it. And therefore, what will be the fallout when we get past this period? How will the adoption stay? Will it stick? Will people want to keep using it, or are people desperate to return to how they did things before? So there's something to be considered there about, you know, how we make sure those pathways can continue when we start to develop them, and maybe do some reactive business change after the fact with some of that. And I was reading something this morning on LinkedIn about the across in America, and they're in a lot of ways it's exactly the same. There's been a huge acceleration in video consultation, telehealth, telecare, and what that's driven, and what we will discuss later with Adrian, is how this has driven private companies to really start upping their digital health roadmaps, and that's going to force the consumer market possibly ahead of health and social care. And just with the second quote there that's come from Bradford Teaching Hospitals, where she said, video conferencing is something we could have done 1 or 2 years ago, but it was slow to get off the ground, not because of technical issues, but because of the people. So that business change element. And while it has been driven, there's still things that will need to be worked out post-COVID. So if we move on to the next slide. Oh, it's gone blank. So this next one, I just wanted to point out this week, literally, the National Audit Office issued a document about digital transformation in the NHS. And I think it's a really interesting read, particularly in light of what I was just saying about some of that business change wasn't done. Because some of the points that have been in that, and I'm quoting from it, is that we haven't really learned some of the lessons from before. So from the national programme and pre-national programme and all of that work that was done, and all of the reports that came out. So if you haven't read the Wachter report, I really recommend you read that Making IT Happen by Robert Wachter that came off the back of the national programme. And also further back in 2002, Professor Dennis Protty wrote a report on digital transformation. And again, I'd really recommend those as reading, because they still seem relevant today. And whilst we do move forward in small incremental changes, sometimes we haven't learned the lessons, and the National Audit Office report is pointing that out. And even though we've moved forward, we've really got to think about how we do manage that digital transformation across health and social care in there. I will share this, hopefully the slides will get shared afterwards and you'll have those links. The top one is the Wachter report and the bottom one is the new National Audit Office report from this week. If we could move on, so then there has been also within all of this some successes for SMEs that have. There was a TechForce 19 UK bid that went out for 25 grand for small businesses who could really help support the communities during COVID. And myself and Adrian and a lot of people in the Innovation Agency had to review 1,500 products in about 3 days, I think it was, Adrian, wasn't it? That applied for this grant. And out of that came these winners. And these people were really pushing to help support patients and citizens at home and manage them through this period and lockdown. So there was some small businesses really got a push out of the back of this. And again, Adrian will play to this in a bit later on, but again, it's showing that there's a consumer-driven side to the technology that health and social care might not be able to keep up with, that people are more willing to look and adopt things that help them manage their own health in their home environment. And they're more adapting to that. And again, like I said, Adrian will talk a little bit more about that in his slides, which are next.
If you could, thank you. Right, thank you, Jenny. Yeah, as Jenny mentioned, we've seen a lot of change over the last few weeks. So it's how we managed to accelerate this so quickly. Well, I think the answer lies in that we're more connected than we sometimes think we are. If we look at a few stats here, we've got 87% of UK households have internet access, 82% of people using home broadband, 70% of people using 4G mobile services. If you look at things like Google's daily searches, there's 70,000 a minute that are health related. And 43% of people who go online to find out about medical conditions and treatments, they already do that. 60% of people who do that, they don't go on to use another frontline service. So there's already an appetite out there. We're already very connected. This is all information from Ofcom, Google and NHSE, so we can share links to that if that helps. We do still have to remember though that digital exclusion is still a challenge. We've got almost 12 million people in the UK who don't have digital skills, 4 million who've never used the internet, 1.9 million households completely cut off from the internet. And although many people do have internet access, some of those people only use 5 apps or websites. But whilst there may be a digital divide, if people are happy to access healthcare using some of these new routes, it can free up resources for those who cannot or don't wish to. Could you move the slide on, please? So we've seen over recent weeks a shift to the new total triage model of accessing primary care. So how do you access your GP? And that's where you submit prior information, which is triaged, and then the response is either an online message, a video consultation, telephone consultation, or a face-to-face consultation. And already amazing results are being seen from this. One surgery has reported that they've taken their waiting time down from 3 weeks to 1 day, and then to just 30 minutes for an appointment. Staff are reporting that they've now got more time to look after their patients better. So they're doing more proactive things around regular blood pressure checks, rather than just being reactive. There's improved patient and staff satisfaction, improved efficiency. And also that system, it's proving to be more resilient in terms of the flexibility to cope with self-isolating doctors, self-isolating patients, and even the temporary loss of practice premises. There was a link on the previous slide to a summary report of a webinar that was recently held by the Academic Health Science Network, which makes for some interesting reading. But in summary, prior to the pandemic, 90% of practice work was done face-to-face, and it's now moved to more like 90% remote or online. So how are people accessing these services? Could we go to the next slide, please? So it's largely smartphones. They are the most popular internet connected device. We've got 79% of UK adults owning and using a smartphone, and the internet access on smartphones, as you can see, increased from 20% in 2008 to 72% in 2018, and already 66% of visits to nhs.uk are on smartphones. Now, it does vary by age. As you can see, younger people, 100% use their smartphones to access the internet. It only starts to really drop off once you get to 65 plus. But then, as I mentioned before, if the majority of people are able to access services via the device that's in their pocket, then it does potentially free up resources for those people who are unable to or who do not wish to. We do have things like a proliferation of health apps. We've got 327,000, I think, at the moment available for download. We've got organisations like Orca who provide trusted review and accreditation. So it's not perfect. You know, they found that 65% of those 327,000 haven't been updated for over 18 months. So it's important that we have organisations like them who are able to help people navigate that market. But it's not just about accessing information and services via your smartphone. Could we move on to the next slide, please? So we've also got other sources of data which are proliferating, which are helping target smarter preventive healthcare. So we've got these devices that monitor our activity, our vital signs, our environment. They're all proliferating. Every second, 127 new Internet of Things devices are connected to the web. These are all these devices that we're finding in our homes, our wearables that provide data. Technology-enabled care is playing an increasingly significant role. And by that, I mean the sort of the convergence of telecare, which is traditionally your local authority response to home monitoring, so pendant alarms, activity sensors, but then telehealth and telemedicine, which might come from a health provider. But as sensors get more and more refined, these devices are converging. So the same sensor could measure your heart rate, your respiratory rate, also your activity. So it will be less about specific devices to measure specific things, but we're more moving to a state where devices will take in multiple forms of data, and it will just be about how we then consent to share that data. As mentioned before, these devices are proliferating. At the moment, I think we're looking at something like 35 billion Internet of Things connected devices by next year. And if we allow the data from these devices to be shared into our health and care record, there's an opportunity here to then start to produce some real insight into our own health and care as more data layers interact with each other, possibly using AI. This does raise the issue around consent, and we do need to make consent easier and more dynamic, explaining the different levels of consent and allowing people to change their mind at any point. But it does mean that it can be made more dynamic that way, and that the person themselves becomes the data controller, which could then overcome some of the issues that people still experience around restrictive data sharing agreements. So as I say, if we start to allow data from all of these different sources to be used in predictive and preventive approaches, we'll see some potentially very interesting applications in health and care. Could you move the slide on? So there are some other things which we'll be seeing over the next few years, which can potentially act as enablers or will be trends. We've got issues like the analog telephone network will be switched off by 2025. Everything will be digital by default. Now, that has some implications for traditional telecare services, which operate on a analog line. So that's your sort of pendant alarms, your home monitoring. But what it does mean is that it suddenly increases digital connectivity in homes which don't have internet access, because if everything's digital by default, you've then got a data connection. So it does potentially start to reduce that digital divide. Similarly, 5G, as that becomes more prevalent, there'll be this always on, low latency a phone signal, which can enable new applications. So low latency refers to sort of the no lag. So it can enable things like remote surgery, continuous monitoring, augmented reality. We're already seeing applications of augmented reality in things like virtual physiotherapy for stroke rehab, where people interact with virtual objects in their room, and the boredom that people usually get into with traditional exercise routines is massively reduced because it effectively gamifies that experience. It becomes something that people interact with more, and people push themselves a bit further than they might usually have done with a series of just set exercises. As mentioned before, some of the continual refinement and proliferation of sensors and connected devices will change some of how we have our health and care provided. Because as we gather more devices in our homes, and as Jenny mentioned previously, these devices, things like your Alexa, your Nest, your smart meters, intelligent door locks, connected kitchen appliances, all of the providers of these are all interested in collecting data about you. They are also interested in becoming players in your health and care. There will be a lot more data collected via these devices. The International Data Corporation predict that the growth in connected Internet of Things devices is expected to be generating 79.4 zettabytes of data by 2025, and that's 1 trillion gigabytes. I'm not sure what the figure is today, but that's a very significant amount of data. So Ofcom, in surveying people, found that 79% of internet users felt confident about managing their personal data online, and they felt happy for companies to collect information about them under certain conditions. But when you see it in the light of how much connectivity we will have and how much we will be sharing data potentially in the future, are we actually happy and comfortable with that? And I think if we move on to the next slide.
Thanks, Adrian. So in light of what Adrian has just said, this is going to lead on to a question where we kind of want some interaction from you as well. But I wanted to just show you that this is another recent report that's come out within the last week or so from .Everyone. So .Everyone is a think tank, and it's run by Martha Lane Fox, who, if you anybody know lastminute.com, she left that and set up this think tank to start looking at ethical use of technologies. And I really like some of the work they've done, and it's really worth having a look on their website. They've done some great work, and every year they do the People, Power and Technology Digital Attitudes Report. And just some interesting things that came out of that report are that they're saying that in this year's report, people finds that people continue to feel the internet is better for them as individuals, but for society as a whole, not so much. So 81% said the internet has made life better for people like me, but only 58% said it had a positive impact on society overall. And also one of the big headlines that came out of it as well is the mistrust of tech companies' motives. 19% apparently believe that they design their services with people's best interests in mind, and they feel powerless to influence what they do and are resigned to services where harmful experiences are perceived to be part of every day. And that's quite a sad reflection on us. But I mean, I know I download things like Facebook and Twitter, and I accept the terms and conditions without even thinking about it, because I can't get the app if I don't. So they've kind of got you in a bit of a catch there, and I certainly can't be bothered reading pages and pages of what that looks like. So again, it's just another interesting report to have a look through, and they do it really nicely to kind of make it easy reading. But it leads on to something that happened during COVID that we thought we'd have for discussion. So could we move on to the next slide?
Yeah, I think, I don't know whether Adrian wants to take it, but there has been some questions for Adrian. I don't know whether he wants to take them now or you want to do them all at the end.
Could we look at them maybe at the end?
Yeah, lovely. So we'll keep going. Thank you.
So the next slide. So what happened during COVID, and you're probably all quite aware of this. And I'm a member of the chatter that's, a lot of you might know the channels, discourse channels, that's open to all the digital leads, and the CIO channels on there. It's a national channel just for sharing ideas. So over COVID, I've been keeping a close eye on what's kind of been the headline discussions. And outside of video conferencing is this sharing of data, particularly with supermarkets. So there was a particular issue that was raised that somebody had put forward Waitrose had sent them an email saying, we are contacting our regular customers on the list of clinically vulnerable people living in England and Wales, which the government have shared with us. And they said, is that justifiable and appropriate for what they've done? Because whilst it does provide a service and it's helping those people at this point in time, we can't take that data back. And what actually was shared with those supermarkets, they already know huge amounts about us. What does this now have implications for us when they now know, on top of that, your clinically vulnerable status, potentially? So we thought we'd kind of open that question to you, because that was kind of an interesting topic of discussion that was on there. And how, how do you feel about it? Do you think it was justifiable? What are you consider? Has it set a dangerous precedent? And what are the future problems? And I should have said before I started talking, if you want to put your hand up and have a comment on that, that would be great. We'd just like to, just be interesting to know what your thoughts were on it, because this is something very specific that came up during COVID. Anybody got any thoughts on that?
Lovely, thank you. I mean, as you say, my mum actually, Jen, was one of these the people that added that data to them, and it was actually a chore for her, to get her data from the GP and a code that then had to be sent, and so it was very sort of complicated at the time. And I remember her saying, I can't get a delivery unless I do this, and so it was a bit of a worry, really. And I don't even think that sharing that data was even anything that entered her mind. It was more, as again, like you said, that power thing around, if I don't do this, what will be the consequence.
Yeah, and it was used. In some ways, I suppose, knowing that allowed people like your mum to get that delivery. But I suppose it's the implications post this all happened, post COVID.
Yeah.
What do we? So I think Lynn Riley has got a hand up.
Yeah, but let's have a look. Lynn, I'm just going to unmute you now so you can contribute. Hi, Lynn, can you talk?
Hello. Can you...
Hi, Lynn. Hi.
Hi, Lynn.
Hi. Yeah, I mean, I think interesting debate. I mean, I think one of the interesting things is I have a personal friend who's very senior in one of the big supermarkets. And one of the big delays that they had was that under data protection laws, they gather all sorts of data about us, but they're not allowed to ask for your age. So I was quite keen to try and get my 80-year-old mother on an online shop, but couldn't get her prioritised because I couldn't evidence her age to the supermarkets. The irony, of course, is that they probably worked it out for themselves because they know what my mum goes to the shop and buys. So the people buying, I don't know, hairnets and Garibaldi biscuits probably are likely to be of a certain age profile.
Yeah.
So I think it's very interesting that we get very hung up about data, but actually, probably Google knows more about my medical conditions because I'm Googling it than my GP. So I think that's the dilemma, that we're really worried about sharing data, but the big tech giants know more about us than the people that are we trust with our healthcare.
Yeah, and I mean, I do agree with you. I did say when I was talking to them about this that I am more concerned about what Amazon know about me than I am about, some of the healthcare organisations. But it's worrying whether it's because in some ways they don't. Well, they might be able to take a guess at some of your clinical conditions, I suppose, but this is actual data taken from the government and shared quite freely with these big supermarkets. And I don't know, I mean, somebody has said in the thing, it is quite troubling because it might set a precedent that allows that to go a bit further without us really knowing that it's there, I suppose.
Yeah, I've just now you've mentioned the chat. I'll just read a few things that have been said and then we'll go to Ben Salem. He's got his hand up too. So what they are saying is, let's have a look. So 1 second. Okay, I'm just trying to navigate. So strict regulation will be required to prevent data being exploited by companies, organisations and the government. And in the current context, the individual benefits were more than the risks. People don't know much about these supermarkets and how they're using data. Absolutely. Bear with me. To what extent? And you know, Joe's fair point, you know, it's well intentioned but troubling. You know, was there any consent involved beforehand? If that data helps suppliers offer better services to the society, that would be good value added. And the last comment is that I agree, is that the agreements in place prevent exploitation of our vulnerable society. Yeah, really good. Ben, would you like to contribute? You should be on mute.
Yes, can you hear me?
We
Yes,
can.
yeah.
Okay, hi. Good morning, everyone. This is, I just wanted to raise the point that there's been a debate about the issue of data and privacy. From the days of the air miles, I used to live in the Netherlands, and there was a company that launched a scheme whereby you could collect air miles from shopping, and those air miles will be used to book air tickets. So you would have both supermarkets and airline companies knowing about you and your habits. And I was at the WAG Society, which is a kind of organization, para-governmental organization in the Netherlands that deals with technology and how it's accepted in the public. And we had this debate about data and privacy. And the big conclusion, which I want to share with you guys today, is that there's two things. The first one is the key point is for the individuals to know what their data are going to be used for. So I'm willing to share as much as you want about my private life if I know what it's for and how it's going to be used. So when I go to my GP, they might ask me very personal, very private questions, and I have absolutely no problem answering them because I know that he's trying to figure out what is my health problem. So it's very clear. But the problem arises when you have all these airlines and all these supermarkets asking more and more data, and you're not very clear what is it for. A good example, on top of it, they have all these data breaches that keep happening, like the last one from EasyJet, and they take time to contact the customers that are affected. So it's both the individual being informed of what the data is for and how it's going to be used. And the second part, which is a very difficult one, there is a need for trust to be built between the individual and their data and the companies that are collecting, managing, processing, and using their data.
Yeah. I agree with all of that. And I think that it harks back a little bit to what Adrian was saying about consent and us being able to have dynamic consent with our help data and be able to understand where it's being shared, how it's being shared, for what reasons. And we need to be more in control of that. I mean, again, it goes back to that .everyone report saying how we have a deep mistrust of technology in terms of what they're doing with the data, and we feel powerless to influence it. When you start involving some of these big companies, I think that's possibly where a lot of this mistrust will come from, and that's something we've got to try. I mean, you would hope we would try to figure out, but then again, as somebody has put on here, it's hard to imagine any kind of retailer will prioritize ethics over profits.
That's a big question, I guess.
But I agree with all your points there. I think that, you know, it's right, and we should be trying to build trust. And I think in terms of this, we need to know what that data was. Well, you know, because it might have been very little they shared. Like you were saying, we might not be able to share ages and things, but we don't know what was shared. And I think that was people's concerns in the chatter on that particular forum, that without knowing and without, because once it's out there, you can't get it back. So it would just be, we should be well aware of what was shared and how then that was used and what that company was going to do with it post-COVID.
Yeah. So we've just had another person in the chat, and then I'm going to move to Saeed, and then we're going to go to Lynn. who raised their hands. Leanne's put the other problem is that there needs to be contribution of these giant companies into our society. So it might be for paying taxes, for example. At least that way we can have some benefits. Yeah. And it's not a one-way street. So Saeed, I'm just going to unmute you and allow you to talk. You had your hand up. Hi, Saeed. Are you there?
It still looks muted, Carla.
Yeah. No. He should be, but maybe he's not able to do that. We'll move to Lynn. Lynn, we'll go back to you and come back to Saeed. Yep, so you should be able to unmute yourself now.
Can you hear me or I wait?
Oh, hi, Saeed. Yeah, we can hear you. Yes, thank you.
Can I make comments? Quick comments?
Absolutely, thank you.
Yes?
Yes.
Thank you. For the supermarket data, this has been very well advertised and been marketing and in the media, even globally. You're right. There are some maybe benefit in some set of data, which is good for health and well-being to the NHS or Department of Health and Social Care. But I think the majority commercial and business sensitive. If you go to the breakfast cereal, whether you buy porridge or Weetabix or you buy Frosty, if you have diabetes, so they study the behavior of the shoppers. You're right, there is age, gender, and so on, but mainly commercial, which products sell quicker, whether they put chocolate at the checkout or chewing gum, or they put something healthy bar. It's all to do with that, but there is an element of health in it, and that has to be agreed or controlled through the Department of Media and Internet, or maybe the control, whether the commissioner, maybe there is a body somewhere in the government or independent to control these data, but it's become global. The problem is if you go to Asda is part of Walmart based in the US. Now, where is the source of these data collected? It's a bit of challenging, but it needs control. Anyway, that's point number one. On your presentation previously, I think there was some, not challenges, just a comment for the COVID-19, the data. The trial now in Isle of Man, you have to have a smartphone, the tracking and blue coat is coming to the northwest and is going to be implemented in the rest of England. I don't know about Wales, Scotland and Northern Ireland. And I think there will be some challenges in terms of the location, how you're going to identify the data. I know Boris in the parliament yesterday said he recruited 22,000, maybe by June 25,000. But there is some challenges in identifying, analyzing the data, because as you know, the problem with the patient and NHS priority, but there isn't given much priority to the care home. Now the care home has become top priority because there is capacity in the NHS bed. Now, the same analysis maybe when we'll start with the tracking and using the blue code, which area, how many people, and so on. So there are some challenges, but it will be interesting to see when the system will be implemented. And I see maybe some SME or innovation agency will get involved in the IT and the digital business of the analysis. Okay, thank you.
Thank you, Saeed. That would know you all great points actually. And when you mentioned something just then about the data market, you said about Asda being with Walmart. I know in all kind of implementations I've been involved with digital work, we've always been like, where is that data being held? It must be held in the UK. Now, actually, if we've gone and shared something with Asda, who, like you said, are owned by Walmart, have they kept that data in the UK? Do we know that? Because we're so hung up about it usually. Have we let something like that slip through the nets? That's quite an interesting point I hadn't thought of. And also, it also reminded me of conversations I've had recently around AI, where we're saying once AI really starts to get a grip and take hold, when they start to use this data, and if they've got some of your clinical data, like you were saying about a diabetic buying a sugary treat, would it come up? Are we starting to get into the realms of them going, should you really be purchasing this? There's that kind of sinister side of it that starts to appear, like Adrian said before about all this data held about us. It starts to form a picture, and you start to wonder what the future of that being used is.
Yeah.
And that's fine if you want that feedback, if you want that sort of, you've consented to share your data, and you want that insight that if I purchase this is the impact it could have on me, and then you can make a choice. But not everybody wants that. So it's about, you know, how we consent to that, and how welcome that might be for everyone.
Yeah.
Shall we move to Lynn?
Yeah.
Hi Lynn, you should be able to be unmuted now. Yeah.
Hi again. Three quick points. I do think this is all about empowering the patient. I'm an elected councillor, and during COVID, it's been absolutely fine for me to knock on my neighbour's door and for her to tell me in intricate details about her medical condition, but the local GP couldn't share the data about her with me because I'm not trusted. Trusted by the patient, but not trusted by the system. Also, I've just started using the NHS app, and the data held on me is pretty poor, and I'm not trusted to input to my own care record, which I think is pretty poor and needs to change. I think as well, my husband is currently going through cancer treatment, and you sort of invest quite differently when you're actually quite poorly. And one of the things that seems to hold up a lot of drug innovation is the ability to find people for clinical trial. And obviously, as we've been able to, map the genome, diseases have got very, very, very now specific trace and markers. And actually trying to find people in the global scheme of things to put on clinical trials is the thing that slows up drug innovation coming to market. Now, anybody with cancer, once you've got over the shot, you would sign up to anything that's going to, one, prevent anybody else going through what you want to do, and two, might find a cure for you. So I do think there's a bit of responsibility in the system to actually think about the patient rather than the process, the system, the policy, and the politics of it all.
Yeah.
And finally, my final P is one of planning. There's an awful lot of things that we can do that we choose not to do. So, in the planning system, for example, every supermarket has to have planning consent. They have to have licensing. And if we only added health as one of the pillars to determining legislation, we could do really sensible things like every supermarket puts the fags at the front. We ought to make people walk to the very back of the supermarket and make it really difficult. We ought to be able to put chocolate on the top shelf right at the back. And we could do that in legislation, but we need health adding to the four harms that sit in licensing and that sort of legislation. So we need to be pushing this, and I don't, it's all above my pay grade, but it drives me mad that you can't do sensible things locally because there's always a bloody system that gets in the way.
I totally agree with you there, and I think on those points around your own medical record, the ability to control and share that and input into it, because your data is just as valuable as what a clinician might write in your record. Patient health data is absolutely paramount. This is why we need to move to this sort of dynamic consent model. So you could choose to share your information with your neighbour because they might be involved in your health and care. You may choose to share your information with people doing research. So it's different levels of consent, and until we've got, and people are working on this at the moment around a sort of this blended model of consent with different levels there where people can dynamically change. Information will be held in the wrong places, and we won't be able to get as much out of it as we need to. So I absolutely agree with you on those points.
And Lynn, just again on that, when you're talking about that bi-directional offer of data between yourself and clinicians, I mean, there's a lot of work been going on for again a while now around this, and there is obviously the Empower the Person work stream. against the long-term plan, and part of that is about developing the longitudinal care record from cradle to grave of people that you do input into, and that system, so the clinical side does, but you also input that data in, and it also there's the work on allowing you to share that data, so either share that data with a carer, with somebody who you trust, so that you give proxy access to your record and allow them to input into that. And that's a work stream that has been going on for a long time, but the NHS is it can be a slow beast, and there's a lot, like you've said before, there's a lot of systems, a lot of governance involved, and it's slow to change. And it's something that COVID has driven that video consultation forward, but we've still got a lot of work to do behind the scenes, and cultural people having that cultural change, that the patient's data is as valuable as the clinician's data as well.
But I do think the dynamic has changed now. COVID has changed the world in ways that we don't yet really, we've not analysed it, understood it, evidenced it. But people will not put up with, months to make ethical decisions, months to do procurement and death by consultation. People are going to want to move things on a lot quicker than the NHS has traditionally done. And I think, the culture will change, and you might as well go with it.
I think you're absolutely right there. And I think what people have seen is that there has been such seismic shift in the last few weeks that people are looking at that in the NHS and going, well, how have we managed to do that when we struggle in other areas? And how do we apply some of the pace that we've used there to other areas so things don't take quite as long?
Yeah, and Lynn, we've got Leanne on the chat as well, and she's saying that you do make a good point. Patients should be owning their own data, not anybody else, and innovations should enable it rather than being companies or government.
Yeah.
So lovely. Thanks for contributing, Lynn.
Okay. Should we move on to the next slide? Because we've got another one to discuss, actually.
Absolutely.
Okay. So the other thing we were going to put out to you, and again, this is one that came up in the chatter over COVID, about the consultation room of the future. I mean, what do we think that might look like? How do we think it might work? How will consumer products support that? It plays into some of the talk we've just been having about the patient owning the record and being contributing, and what Adrian was saying before about the consumer-driven market is ramping up, and they are accelerating their digital health roadmaps. So what do we think the consequences of that be? What do you think that consultation room of the future might look like? What do what are your thoughts on that? It's just a throw open to you to see what you think how that could work.
Lovely. So we've got Ben. You should be able to unmute now.
Yes, can you hear me?
Yeah, lovely.
Yes, you can see I'm traumatized by the mute button. I have to check it. Well, I'd like to report here on something else. There is this series of conference on pervasive health. And a few years ago, there was a presentation from the Mount Sinai Hospital where they were looking at the consultation room of the future. And what they were implementing was, for me, a bit strange, because they saw it as being a physical room surrounded by a lot of monitors and displays, where the patient will come in, be greeted by their doctor, and then they'll be presented with absolutely all their medical data. And at a glance, they can look around and they could see all the parameters that relate to their condition and also to their well-being and their health. And the idea was to change the consultation room from one where the doctor will inquire from the patient what's going on, what are the problems, what are the ailments, what are the symptoms, to one where the patient will be presented with an analysis and an overview of all the data and be given immediate advice like, well, you need to do a bit more exercise, you need to lower your alcohol intake, and so on and so forth. So there will be a change from a kind of an interview where the doctor tried to figure out what's going on to a dialogue where there's a discussion not only of medical issues, but also behavioral and dietary issues to make sure that there's a holistic approach to caring for whatever condition the patient has. The other reason why they were doing that is cost. The US, we're blessed here to have NHS where cost at the patient end is not consideration. So when you go to the hospital, we don't care about cost. We don't even have something to pay. Well, and it's a very interesting, peculiar thing to the UK and few other countries. While in the US, it is a big issue. So for them, doing this, having this type of consultation room will enable them to have very short consultation with some patient who can't afford the full price, if you want, of the service. And they could then scale depending on the insurance cover that the patient has or the lack of it. They could scale up or down what information is presented and how much discussion, how holistic their care and their discussion will be. That's the vision they had. Mm-hmm. I think for my part, I'm trying to get a project. I'm from the University of Liverpool, by the way. I'm trying to get a project on having more of the technology, more of the monitoring, more of the, if you want, observation of the patient done at home. And then what's left with the doctor and with the healthcare professionals is decide on agreeing on the diagnosis and agreeing on what needs to be done and agreeing on the cure and on any further actions that need to be done. But that's my personal view on that.
No, and I think that I think I've seen a similar presentation, well, not presentation, but it was a kind of a video where they detailed this out. I think my only thoughts on that, I recently was in America. I was in Boston and was chatting to some of to Mass General actually, mm-hmm. about some of the issues they have. And in America, I obviously know it's a different model. Problems are the same, but obviously with their insurance model. And the big issue that was going on there is sharing of data, because they're all private companies delivering different parts of the medical system. And especially someone like Epic. So Epic's a huge electronic patient record supplier, particularly in America. And they were suing the federal government for them insisting they had open APIs because they do not want to share data. Now, in England, we are all for driving open APIs and our LICRAs, if you've heard of them, the local healthcare record exemplars, are all about opening up the system, sharing the record across all forms of health and social care, and allowing the patients to input their data back. But in America, they're quite close, and then you've got one company suing the federal government for wanting them to share the data.
I think you have here, sorry to interrupt, but
that's okay.
Here a very, very important point is that the consultation room of the future will be a data warehouse, essentially. It will be about processing data. And it's a bit scary because maybe I'm a dinosaur or I'm old-fashioned, but for me, the human contact with the healthcare professionals in my GP practice and the hospital, shall they be, from all the way from the receptionist all the way to the doctor, to the nurse and everything, is very, very important. And it gives me a perception that the system, if you want, cares for me, and that I matter. I'm not just a number or an individual. I am myself, and they care about me, and they're trying to make sure I get the cure that I need. Now, if the consultation room of the future is just a data warehouse, basically, then, and as we raised the issues before, we don't even know where it's going to be processed. Is it processed in the UK? Is it processed in some subcontractor, some in a different continent with different laws and different approach to medicine? Who knows? And these are big issues for how consultation should run in the future.
Yeah, I completely agree with you. It's very interesting, but obviously there's lots. It's fraught with issues along the way that need to be worked through.
Thanks very much for contributing that, Ben. That was really interesting.
It was.
So we're just reading some items off the chat as well. So Leanne feels that a lot of the information will be available before the consultation through devices, which is really important as well. How many times do you feel that you're repeating yourself and you're unprepared maybe for consultations? That would be great.
I could also add to that as well, that if you have got connected devices in your home that you've enabled sharing, that actually a lot of your information will have contributed already to your diagnosis.
Mm-hmm.
So how often have we been to the doctors when we've been told, well, actually we need you to go and wear a 24-hour ECG, or we need to send you for this test? Actually, if they've already got some of that information, it can make the diagnosis a lot quicker.
Yeah, and as Leanne says, you know, it will enable closer to home care as well, which is key. And we've got the next comment. Let's have a look. Yep. So from, I hope I'm saying your name right. So Bhaskar Raju. Interoperability and portability of data is a big challenge in America now. We started those American EMR/EHR companies coming into the NHS trusts big time. Likely it'll pose more challenges here too.
I think over here we're very strict that if you work for NHS, you share the data. It's not yours to keep, and that's a philosophy that's rolling through the digital world. That we are open. If you're coming to play in our back garden, then you play on our terms. And our terms are, we are sharing the data. So there's a slightly different slant on it in the UK that they can't argue with, because if they want to play, they play nicely.
Very interesting. And the final comment is, if the consultation is being recorded and kept for a certain period, then there will be implications for storage of data, as it will generate huge amounts of storage of data. I mean, you know, how many images or things do we have on our phone that we never get rid of? You know, I think it's a problem for everybody, really, isn't it? You know, data storage too.
And you think photos are bad, wait till you start trying to sort Diacom images from X-rays and things.
Absolutely.
But I think what we do see though is that progressively compression methods and size of data storage just keeps on increasing. So I suspect
Great point.
we may not get to that point. I don't know though.
So Lynn, I'm gonna allow you to speak. You can unmute now.
Okay, thanks. Pretty much everybody on this chat will drive a car, and a lot of the technology that sits in our car now was originally developed for Formula One. So, you know, I think the consultation room of the future will basically change the power dynamic. Yes, it might be I'm sure it will be a huge digital warehouse, but, you know, if Formula One drivers can have all the telemetry in their driving suits, and you know, championship footballers have got the telemetry in the back of their shirt, so you know you can actually map all of their biometrics and where they are in the pitch and their interaction with others. You know, there's all sorts of art of the possible for certain consensual health applications of wearable tech. So I think that's something to think about. But it's the power dynamic. And I think one of the big power dynamics that needs to be factored in is the focus needs to be on wellness, not just on treating the sick. 80% of what keeps us happy, healthy, and mentally and physically well is nothing to do with visiting a clinician. And I think, you know, the NHS has got to start thinking about where its consultation rooms might be best placed. And I'm shooting from the hip here, but you know, it's, you know, we have personal shoppers when we go and buy clothes. Can the supermarkets not think about personal shopping, you know, on a referral basis for people with, you know, clinical conditions? There's all sorts of things that can actually be win-win situations, but we've got to reimagine the world very, very differently. And it's very blended compared to, you know, you're sick and go to the NHS, you're well and you don't. I think, you know, the NHS has got to change its mantra and start keeping us well, you know, and be there for us when we're sick. And that's got to be the power dynamic. And until the NHS steps into that space, don't be surprised when others will try and use the data to occupy it, like the supermarkets.
Yeah, and there is a big population health agenda behind the LICRAs, the local health and care record exemplars, that is more about a preventative agenda and starting to tackle that than it is about responding. to somebody's healthcare needs. There's more about that preventative agenda, and that's being built up. Again, it's all quite slow moving stuff within the NHS. This has been going on for quite a few years. Some people are further ahead than others. A lot of it comes down to cash. They haven't had the money to invest in some of this, where you've got a commercial company who can invest millions and they have their profit lines. The NHS doesn't have that, and technology has always had to prove its worth before you implement it. And some of this cutting edge stuff, you can't prove it before it's implemented. You can take a guess at it, but they can't prove it.
Can I come back with a challenge?
Okay, yeah.
Having been through very expensive cancer treatment and brain surgery with my husband, you know, this argument that the NHS has no money is a valid one. We all get it, but the amount of wasteful bureaucracy that we have lived for the last year is scandalous. So I think before the NHS starts moaning about, you know, we need more money, they need to look at, you know, and a lot of this comes down to how we use data, how we organise our bureaucracy, how we book blood appointments, scan appointments, all these sorts of things. It is so prosaically anarchic that all of that money that is wasted on bureaucracy could be front-loaded into, you know, frontline innovation.
Yes.
And we would cheer. We'd clap for that.
Oh, I know, and we're with you. On anybody on the digital side will be absolutely with you. People want to invest in it, but it comes down to priorities. I mean, I'm just looking back at the National Audit Office report, because this came up within theirs, and they're saying a lot of trusts are not spending, because it's recommended that trusts start to spend at least 5% of their budget on technologies to drive forward, reduce inefficiencies, really start to look at how they plan their pathways. And only most trusts are only working at 2%. Because a lot of the time when they're looking at their budgets, technology is a secondary thing to some. Not to all, there's some really ones that are driving forward and are innovative trusts. But it comes down to when those trusts start to look at their budgets, it's a frustration within the digital world. Sometimes you can see the art of the possible, you could see what you could do, but it's getting people to invest in that.
If I could come in there, I think what's happened though is that with the acceleration that we've seen over the last few weeks with COVID, that a lot of that is now being applied to other areas around outpatients and multidisciplinary teams, and realizing there is this wastage, this over bureaucracy, and actually people already have the technology in their homes to interact with the NHS in a different way that is a lot smarter and is a lot quicker for people. So I think we'll see things that people have struggled with for quite some time and got too wrapped up in detail. Some of that, shaking some of that off and just going, we just need to do this now. And I'd also add into that, you know, when you've got things like the consumer market, mobile phone manufacturers looking at medical grade sensors in mobile phones next year, everybody will already have the equipment to collect a lot of information. So that takes the burden off the NHS. If people are happy to share it, that can have a big transformative effect. So
great point, Adrian. Absolutely. I mean, we think, you know, we've got my phone sitting here now, it's got 3 cameras. I don't know, you know, I don't know why I needed 3 cameras, but it has. You know, I'm wondering what else is going to have.
And that's the thing, a camera module in a mobile phone, it's about $15. Medical grade sensors are coming out at about $4 to $5. So why wouldn't any mobile phone manufacturer put those in? Because it opens up. And I talk about, you know, your phone or your smartwatch being able to, you know, do your blood pressure, those kinds of things. And if it's going to continually be refined and gather more and more information, that saves a job for the NHS. As long as it's you know, certified, it's just how we then use that data.
I really like Chris Davis's comment. Actually, he's put similar to the physiotherapy point previously. The game vibe, the aesthetics of a consultation room could be adapted to make the patient feel as comfortable as possible. I'm actually thinking of the Moving Essences stuff and the way that they a company that projects natural nature images, things like that on the wall. That's been proven to reduce to increase your pain threshold and to reduce anxiety. And you know, in the future the clinicians could communicate through a persona the patient's trusts, and that would be you know, could be another world. Absolutely, really fantastic ideas and comments. But there are a few questions that come up before in the chat and in the question and answer. Could we visit those? Is this okay if we move forward on this? Yeah, lovely. Thanks so much, Jenny. So Adrian, I think this was for you. So there's a question in the Q&A, and is there any update on patient self-care via a portal, was the question.
Jenny, do you know a bit more about that one?
Yeah, I suppose it depends what you're asking about. If you're talking about the personal health record, so whereby you will be able to see your entire record, so not just your GP record like you can in NHS app or any other products like Evergreen or Patient Access. The personal health record will be an extended version of that, where you can see your record in your entirety. And some of that work is already being done on the clinical side, and there's some now starting to come through with the patient side of things as well, to allow you to see visibility of your full record. The bidirectional that Lynn was talking about before isn't quite there yet with most of them. There's some that are very specific apps for like cancer treatment, like My Medical Record, for some cancer treatments, or WellPres being developed in Lancashire, or developing that patient front end that will be bidirectional if it's against a specific condition. Am I talking about the right thing here, or am I off? I'm not quite sure who asked the question. Is that what you were asking about?
So it was
or have I gone off topic?
No, it was anonymous, Jenny. So I suppose if anybody wants to elaborate on that, whoever that was, if you put that in the Q&A, or don't forget, you can always email us about that as well if you want to something more specific than Jenny's answer. We've also been asked if you can provide the links to the documents after the webinar, which they will all be in there. Salem has put, can you share the references of the reports that you mentioned? And I think that was as well linking into I think it says Gen GC. The references and the stats are taken from something available to share after the session. So where did you get those, Adrian? I think you said it was Ofcom, didn't you? You said
various sources, yes. So I can provide those.
Yeah, that's great. Let's just check if we've got any other questions. Oh, so that person says, actually, Jenny, you did answer that question. That was great. Oh, great. So lovely. Fantastic. So so that actually was all of them from before. I just invite anybody that wants to add anything to the session. That's the final slide, is it for you, Jenny? Yeah. So anybody
it is, yeah,
that wants to add anything to the session or have input any more questions, that would be great. So if you do want to chat, if you just raise your hand and then we'll allow you to speak. Lovely. So we've got Saeed. Hi Saeed, you can unmute yourself now so you can talk.
Yes, hi, just a quick question. When is the next session? Will there be any follow-up or any date? Will you let us know? It would be interesting to see. And I think would be maybe useful when the Corona apps start being implementing in this region. It will be useful, you know. So any time scale you're thinking of?
So particularly for digital, are you saying, Saeed?
Yes, yes.
The same thing. Well, we've not discussed that really, have we, Jen? This was part, as we said, of the Innovation Scout, but it looks like you did by popular demand.
Yeah, I am sort of ahead of myself sometimes.
No,
you know? always in advance.
Good question.
We'd be happy to come back and talk again about different things if the specific ones you want to talk about. This has been so useful for us to have that discussion with you and to have those to hear your challenges back to the system. That's been really helpful.
Yeah, I think the media will pick it up as well as it's happened now. It's only trial in Isle of Wight, but let's see how it goes.
Okay.
Thanks, Saya. Great point. So we have got a couple of questions, which is great. Thanks everyone for engaging so well. This is brilliant. So we've got Charles Jenkins. Are you seeing much of an uptake in the use of mixed reality devices such as Microsoft HoloLens?
Oh, interestingly, I'd not heard of this until actually 2 days ago, because somebody wrote an article on Twitter about the use of it. I think it was somewhere down south, and Declan Hadley challenged them back and said, actually, we're using it up here too.
Oh.
So Colin Brown, the CCIO at Morecambe Bay, has been testing this out up there, and it's the first time I'd kind of seen it. So there's work around that happening in Lancashire, particularly at Morecambe Bay.
Fantastic, that's lovely. So we've got Anjum, I hope I'm pronouncing this right, Shazad. How do we link in with academia, local enterprises and commercial partners if we were to introduce AI and digital pathology? Can AI help with this? Ooh, very specific.
I think we probably can. We're doing it. Artificial intelligence was a big headline news before COVID hit, as was a lot of things, and then COVID hit. And we did a landscape review on AI products around the region that we presented back to the Cheshire and Mersey CIOs and Lancashire South Cumbria to try and get a grip, because there's a big AI fund run by NHSX. And again, that was a lot of people put the bids in for the first round that was at the beginning of the year. And we were very involved with that. So we do link with academia and local SMEs and all of that to try and look at what AI can do to health and social care and help support that. I know Andy Cairns is on this call, and Andy has some of his SMEs that are very much linked with AI, and he also does real world evaluation studies with the university. So yeah, Leanne, sorry, that was a very long-winded answer to what could have just been yes.
So that was Anjum's that. No, it's fine. And then we've got a question from our own Andy Cairns. Only a fraction of patients are accessing GPs through video systems, despite a huge shift to remote consultations. Any thoughts?
Yeah, I think a lot of that might have been driven by people are wary to contact them because they think everybody is busy, but they think everybody is excessively busy. My sister-in-law is a pharmacist within primary care, and she was saying how quiet the GP surgeries have become because people just didn't want to bother the NHS at this point in time because everything was so busy. So we did go to remote consultations, and that's supporting the GP practices in not having to have people in the surgeries, and that is being used. But I think there's just been a bit of a shift that people are, I mean, I see it with my mother-in-law's currently got a broken arm and a sore knee, and she's in a lot of pain, but she doesn't really want to bother the NHS right now.
Mm-hmm.
And we keep saying to her, you must go and see someone. Well, I can wait. So I don't know whether there's a bit of that around, and the technology is there, but people maybe are just reluctant to bother the NHS at a time they think we're incredibly busy.
That's really interesting, Jenny. I had a conversation with Louise Waters from East Lancashire, and Louise was champion PhysiTrack, and she's using lots of digital innovations around physiotherapy. And she was saying that they've been reaching out to patients and calling them and doing consultations over the phone or videos, and they're actually really sort of very, very grateful, just so grateful for that outreach. And she was saying, they've said, oh, we didn't expect you to contact us with what's going on, so she was saying that people are just very grateful for any care at the moment that isn't urgent.
And I think that's probably it, Andy. I think there's just maybe a bit of reluctance for people to want to bother the NHS with what they perceive to be maybe, which is why, of course, there's a lot of publicity in the papers with people saying, please, if you have any symptoms, you must come to us.
Yeah.
Don't wait. We need you now. We need to get you sorted. And I think there's a push to kind of get people to come back.
I was on the Troponin national webinar as well with Sue Critchley a couple of weeks ago, and they were saying that the heart attack rate is reduced, has dropped. And we're talking about troponin, so it's people that are presenting with that. you know, illness or you know, seriousness, and it's because they're not going to A&E. That was and so that's again the big push for people to go, you know, if you need to go. Andy's put only a fraction of patients are accessing. Oh no, that's right. That's right. Yeah, we've finished. Oh, there's one more. It was why phone is used, but less video is technology or bandwidth. I'm not too sure what he's saying there.
What's that? Let's have a...
Andy's put, it was why phone is used. Oh, so maybe he's saying, you know, phone is preferred rather than
Yes,
video.
there was something I read about that actually people did just prefer the phone. They weren't so fussed about the video. I don't know where I read that. I did read something about that.
You do pick these things up, don't you? Especially if you're like active on social media. And Charles has put a great, it looks like link around that HoloLens. Lynn has written,
Yes.
digital inclusion is no longer an option. Just because people don't do tech today, it's not an option. The digital divide is accelerating and we need to get everyone digital savvy. I absolutely agree. And I also think on that as well is, you know, it's what level do they need to be digitally savvy? So, you know, do we need everybody to be up to a certain level? If so, what is that? Or how do we actually get people to be advanced as well? So these like digital champions that are within communities that can support, you know, your neighbour or your family, your relatives that aren't so technically able. And then Joe Higgins has put, conversely, people may not be aware of what's on offer. Absolutely, I think there's a lot of that too. And are there patient forums to drive access to new tech that might be available? Jenny, do you know of?
Well, we have our own PPI forum, don't we, with Debbie and Dave Dewhurst. And they look at, so we have an innovation curation panel. And when we get new SMEs, new technologies that come to us, they register on our website, and then we sit as an organisation and look at those technologies and figure out how suitable they are. And some of them, particularly if they're patient facing, we can send on to Debbie and the patient engagement panel, and they can start to have a look at things. And they've been really good actually in the past. Adrian, do you remember the Dorothy story with how that went?
Yes, that was wayfinding in a care home by attaching a tablet to a walking frame for people in the early stages of Alzheimer's, but it didn't really work terribly well. It didn't seem to work in the way that the patient public involvement group would have liked it to make. It was an interesting meeting, but we gave the company some really good feedback, and I think they learnt from that patient and public involvement input, which was really helpful.
Yeah. On the digital inclusion question, Lynn, as well, I mean, I always, for digital inclusion, I always look to the Good Things Foundation. They have done some amazing work on digital inclusion and looking at the fringes of society and where they can support some of that work. And when I worked at NHS Digital, they were doing some big work in Leeds about getting digital technologies out to libraries to start getting people who wouldn't have access to technology to be able to use iPads to access some of their health records. And they've done a lot of work with homeless people as well, which was a surprising fact that apparently 80% of homeless people have a smartphone. What they really struggle with is Wi-Fi and making sure that they can access the Wi-Fi. So giving that, making sure public spaces had that they could access it through. And apparently they also loved NHS App, because it meant they didn't have to deal with a receptionist, which was their biggest problem with accessing health. So the Good Thing Foundation have done some really good work around some of that digital inclusion, and they're well worth a look.
I'm actually just seeing, I sent a message today as well from Chinua Health from Naomi there, and there's free tech available for care leavers now, so the Children's Commissioner can also help and support with that. So that's just come through this morning, which is interesting. But we are officially out of time. Wow. Where is that gone? I just want to say a huge thank you to Jenny West and to Adrian Quinn for joining us today, because it's really important that we we do look at the topics, and as I said, these are the 11 priorities that have been suggested by the Innovation Scouts, but are definitely key for everybody in our system in our Northwest Coast and beyond. And I would encourage anybody that isn't a Scout to join up. They'll get priority in terms of our innovation webinars, and also some coaching and peer mentoring too, as well as you know, accessing information that we've got from the Innovation Agency and being part of a community. So it's always really good for support. Again, just massive thank you to Jenny and Adrian. Thanks so much. It was brilliant. I really enjoyed it.
Thank you to everyone. This has been a really interesting conversation. Just some great challenges back, that, you know, questions that have to be asked, and just really nice conversations. There's lots of things to think about. Fantastic.
Yeah,
and we'll do it again if you want.
Well, I think Saeed has already signed you up for that irrelevance. We didn't even get to have that chat, so that's just broke the ice for me, Saeed. That's going to make my ask a bit easier later. And Andy's Keynes has put, your friendly innovation agency commercial manager is more than happy to follow up any queries. So if you've not met Andy Kearns, he's brilliant. He's one of our programme managers, as he says, for commercial. Ben Salem said, thanks for organising the webinar. Can we get an attendance list? So I'll just check with the data sharing on that, whether we're allowed to do that. And then again, and Jim, thank you to everyone on the panel. It's been very useful and informative. So lovely. We're going to capture the chat. We'll get everybody sent information. Thanks so much, Lynn, and everybody who contributed over the phone, and everybody who's contributed on chat. It's made a real difference to the webinar.